Let's understand the maxillary anesthesia. This involves anesthetizing various nerves which supply different structures. Dental pulp of all the teeth are being supplied by, as well as the supporting structure is being supplied by the maxillary nerve and its branches. Coming to the pulp of the teeth are the anterior teeth are being supplied by the anterior superior alveolar nerve, middle is by the middle superior, premolars is by the middle superior alveolar nerve, and the molars is by the posterior superior alveolar nerve. Palatal structures from canine to canine in the anterior region is being supplied by the nasopalatine nerve. The posterior to canine, that is premolars and the mid palatal region, and the molar supporting structure on the palate is being supplied by the greater palatine nerve. Coming to the course, it's a second branch of the trigeminal ganglion. It exits the middle cranial fossa through the foramen rotundum and it enters into the pterygopalatine fossa. Within the pterygopalatine fossa, it gives off the ganglionic branches, that's the sphenopalatine ganglion. From the ganglion, you have various branches, that is the pharyngeal branch, palatine branches, and nasal branches. Of nasal branches, there are two branches, that is the lateral nasal branch and nasopalatine branch. Nasopalatine branch enters into the nose, the lateral wall of the nose, and it comes onto the floor of the nose and then it enters the oral cavity through the incisive foramen. So various techniques, the infiltration, field block and the nerve blocks. Today we are going to discuss about the various nerve blocks, so starting from the posterior superior alveolar nerve block, middle superior alveolar nerve block, anterior superior alveolar nerve block and the second division block. Coming to the palatal anesthesia or the palatine nerve blocks, starting from the posterior palatine nerve, which supplies the posterior part of the palate and and the palatal gingival supporting structures of the molars and premolars. So area anesthetized is the posterior portion of the hard palate and the overlying soft tissues anteriorly till the first premolar, medially up to the midline. The indications are pain control in the posterior part of the palate, and contraindications are inflammation at the injection site, inflammation or infection at the injection site, or it is contraindicated when there is a single or a isolated tooth needs to be anesthetized. The advantages are it minimizes the number of needle penetration and the discomfort and minimizes the volume of a solution to be used. And disadvantages are it provides a limited hemostasis since the local anesthetic agent is given far away from the area of surgery, and potentially traumatic as the palatal mucoperiosteum is quite dense and tightly adherent to the underlying bone. Coming to the alternative technique is the local infiltration in each areas and the maxillary nerve block. Aspiration chances are less than 1%. The landmarks to be identified is the greater palatine foramen. Just a moment. Landmarks to be identified are the greater palatine foramen, which will be present at the junction of the alveolar process and the palatine bone, opposite the crown of the third molar. Area of insertion is soft tissue anterior to the foramen from the opposite side of the arch. The technique involves identify the landmarks with the help of a cotton swab, apply a topical anesthetic agent, advance the syringe from the opposite side of the mouth, right angles to the target area till the bone is contracted, aspirate. Once it is negative aspiration, slowly inject 0.5 ml of local anesthetic agent opposite the crown of second molar. So signs and symptoms are numbness in the posterior hard palate and pain-free dental treatment. Safety are bony contact and negative aspiration. So identifying the greater palatine is opening opposite the crown of either the third molar or between the second and the third molar. Once it is identified, we have got to anesthetize with a cotton swab, and then you have got to slowly you got to slowly advance the needle onto the you got to slowly uh, enter the tissue opposite the crown of the second molar, about a centimeter away from the free gingival margin. Once you contact the bone, withdraw a millimeter and slowly aspirate and deposit the solution. Coming to the complications of it are The soft tissue ischemia or necrosis, a post-injection pain could be there. Hematoma formation is quite rare, and if this technique fails, sometimes it could be because of the overlying or concomitant insertion from the nasopalatine nerve in area of premolars. Next is the incisive nerve block or the nasopalatine nerve block. This nerve, which is present on the anterior palate, it supplies from canine to canine, that is all the incisors including the canines it supplies. Indication is pain control in the anterior palate. Contraindication is inflammation and infection in the site of injection. Advantages is it minimizes the needle penetration, minimizes the volume of solution to be used, and disadvantages include the limited hemostasis and potentially traumatic since we are injecting onto the palate. Coming to the technique, position the patient with the mouth wide open and extended head or extended neck. Landmarks, that is the incisive papilla, has to be identified, which will be present opposite the uh, in between the two central incisor on the palate. Lateral, you got to approach from lateral aspect of the incisive papilla, starting with a cotton swab, topical anesthetic agents. Slowly, you insert your needle tip into the incisive papilla from one side of the papilla, from lateral side of the papilla. And once you contact the bone, withdraw a millimeter and slowly aspirate. Make sure you're not into the vessels and slowly deposit about 0.4 ml of the solution over 30 seconds. So this injection being on the palate and you're giving it in a very small area, you've got to be very cautious not to apply too much of pressure, but a moderate amount of pressure is required, and you've got to give it over a period of 20 to 30 seconds. Alternatives could be a local infiltration or the maxillary nerve block depending upon the requirement. Aspiration chances are less than 1%. Precautions: do not inject directly into the incisive papilla or the canal, which might directly cause the nerve injury. Our intention is not to injure the nerve, but to deposit the local anesthetic solution around the nerve structure so that we have blocked the nerve. Inject slowly with a small volumes with little amount of pressure. Signs and symptoms: there is a numbness in the anterior palate and pain-free treatment in the incisors. Safety features: the bone contact and aspiration, negative aspiration. So this block, that is an nasopalatine nerve block, can be given in two ways, either by a single injection technique or by the multiple injection technique. Single injection technique is first you identify the incisive papilla and then inject into the incisive papilla from the lateral aspect. Whereas in the multiple injection technique, you have got to first anesthetize the tissue. Preparatory injection is given, which is given as the intersectal injection in between the two central incisor from the buccal aspect. Once the preparatory injection is being given, then the palatal nerve block is going to be better tolerated. So this multiple injection technique is preferred in the patients who are more apprehensive or who are less tolerant to the pain or needle, who are scared of the needle stick pain. So after the preparatory injection, you again go onto the palate, identify the incisive papilla. From the lateral aspect of the papilla, you've got to enter the nasopalatine fossa or canal and then give the injection. Next, moving on to the posterior superior alveolar nerve block, which is also called as a tuberosity block or a zygomatic block, which is also which which supplies the molar teeth except the mesiobuccal root of the first molar, and it also supplies the buccal supporting structures. So this nerve, after it's being given off in the pterygopalatine fossa, it comes out from the pterygopalatine fossa and lies in the infratemporal surface of the maxilla and then enters the body of the maxilla through the small foraminae which are present on the infratemporal surface of the maxilla, and then it supplies the pulp of the molars and the buccal supporting structures. So indication of posterior superior alveolar nerve block is more than two molar teeth have to be anesthetized, and when the supraperiosteal injection is either contraindicated or is ineffective. Contraindication: risk of hemorrhage is too great, like in hemophilia or patient on antiplatelet drugs. Advantages is it is comparatively less traumatic, high success rate, and less number of injection. It minimizes the local anesthetic to be used. Disadvantage is risk of hematoma is there, does not anesthetize the first molar completely, and since the mesovocal root has been supplied with a middle superior alveolar nerve, and no bony landmarks during the insertion. Positive aspiration is approximately 3% or slightly more than that, because we are going very close to the pterygoid venous plexus and the maxillary artery. Landmarks for giving the posterior superior alveolar nerve is the mesobuccal root, maxillary tuberosity, zygomatic process of the maxilla, and the area of needle insertion is a mucobuccal fold opposite the maxillary second molar. So once the landmarks have been identified, load 25 or 27 gauge and syringe, uh, load a 2.5 ml syringe with 25 or 27 gauge short needle, and position the patient, identify the landmarks, and then enter the tissue opposite the crown of the second molar and advance it in an upward, inward, and the backward direction, superiorly about 45 degrees to the occlusal plane, medially about 45 degrees to the mid-sagittal plane, and posteriorly about 45 degrees to the long axis of the second molar. In adults, the depth of the insertion should be about 16 mm, and in the smaller adult or the patients with a brachycephaly or children, it has to be around 10 mm. 10 to 14 mm. Aspiration is must. We have got to aspirate twice to make sure we are not into the vessel, and slowly inject about 1.8 ml of solution. So this maintaining this angulation is important because of the curvature of the maxillary intratemporal surface of the maxilla, which curves inward. So once the landmarks have been identified, once you go opposite the second molar, you've got to advance it into posterior superior medial direction. The failure of this anesthesia are possible if the needle is too much laterally positioned and it is not deep enough, or not too, it is too far superior. The complications do happen, like sometimes when the needle is over penetrated, it can puncture the pterygoid venous plexus, which can cause a hematoma, which huge amount of a hematoma, and you can see the hematoma. You can see the ecchymosis of the tissues as well. This will not have a major implications, but the patients will be horrified looking at the huge amount of swelling. So this has to be managed by reassuring the patient, and a local digital pressure has to be applied to restrict the amount of swelling which forms in that area. Okay, so intraorally, near the tuberosity, we are going to apply a digital pressure for minimum of 5 minutes, followed by that extraorally below the zygomatic arch, you are going to ask the patient to apply the ice intermittently and prescribe analgesics along with antibiotics and muscle relaxants, so that the trismus, which sometimes can appear because of the hematoma, the patient will be eased with that. Next is the and after 48 hours, we have got to ask the patient to apply the hot fermentation, so that the resolution of the hematoma takes place at a faster pace. Next complication could be the mandibular anesthesia, wherein the mandibular nerve is located lateral to the posterior superior alveolar nerve. So when we are injecting, when we are directing our needle, if we stay much lateral to the intended area, then it can block the mandibular anesthesia. Here we do not expect any major complications, but the patient might be a little apprehensive, saying that when they are having a procedure in the upper arch, why the lower arch is being anesthetized. So in that case, you got to explain to the patient such and such a complication has occurred, and it is going to wear off within 2.5 to 3 hours duration, and nothing to worry about. Next, moving on to the middle superior alveolar nerve block. Middle superior alveolar nerve supplies the pulp of the first and the second premolar along with the mesobuccal root of the first molar and the buccal soft tissues and the bone overlying these teeth. Indication is anesthesia of the maxillary premolars only and the infraorbital nerve block failure, or contraindication is infection and inflammation in the area of injection. So the area anesthetized is the premolars and the mesobuccal root of the first molar. The advantages of this is it minimizes the injection, minimizes volume of the solution. The mucobuccal landmarks are the mucobuccal fold of the second premolar or the apex of the second premolar. Apply the topical anesthesia, position the patient, identify the landmarks, and insert the needle about 5 to 10 mm into the mucobuccal fold opposite the crown of the second premolar. Once you're into the tissue, about 10 mm inside, aspirate slowly, make sure you're not into the vessel, and slowly inject about 0.6 ml of solution. This anesthetizes both the premolars. Signs and symptoms include numbness of the upper lip and pain-free dental treatment. Safety features are anatomically safe and relatively avascular, so there is negligible amount of aspiration or positive aspirations noted, and complications are rare. Failure of anesthesia needle if it is inserted too high, not too high enough, or the solution deposited too far laterally into the soft tissues, or a bone of the zygomatic arch at the site of injection is being contacted, then it can fail. Moving on to the infraorbital nerve block or the anterior superior alveolar nerve block, which anesthetizes the anterior superior alveolar nerve blocks and the terminal branches of the intraorbital nerve, which include the superior labial nerve, inferior palpebral, and the lateral nasal nerve. So first you got to identify the landmarks, that is the infraorbital notch. From the infraorbital notch about 5 mm below that is infraorbital depression in the foramen. Once we identify, we got to keep one finger placed on the infraorbital foramen and then slowly retract the soft tissue and go opposite the crown of the first premolar parallel to the first premolar and advance the needle in an upward direction till we contact the superior margin of the infraorbital foramen. The needle insertion is approximately about 16 to 17 mm. 17 mm. Once we contact the bone, you're got to slowly withdraw a millimeter and then aspirate, and after negative aspiration is being confirmed, you're got to inject about 1 to 1.5 ml of solution. This is the premolar approach what we discussed so far. The another approach, that is the incisor approach, wherein the same side incisor crown is being diagonally bisected by the needle. When we are approaching, you got to go diagonally to reach the foramen. Again, the needle insertion will be about 16 to 18 mm, 18 mm in length. Once we contact the foramen, you are going to aspirate and then slowly inject. The anesthesia, the areas anesthetized are the pulpal anesthesia of the anterior teeth, pulpal anesthesia of premolar and the mesobuccal root of the first molar, the buccal soft tissues and the bone of the same teeth, and the lower eyelid, lateral part of the nose, and the upper lip. Indications of the intraorbital nerve block is anesthesia of more than 2 maxillary teeth, supraperiosteal injection if it became ineffective, or inflammation or infection contraindicating the local infiltration. Contraindication or single tooth procedure required, hemostasis if it is required, or patients with a bleeding problem or antiplatelet drugs. Landmark are the mesobuccal fold above the first premolar, infraorbital notch, and infraorbital foramen. Area of insertion is the first premolar, infraorbital foramen. Once the target area is the infraorbital foramen and the neurovascular bundle. Apply the topical position, the patient identify the landmark, insert the needle to the upper rim of the infraorbital foramen and inject about 1 to 1.2 ml of fluid. Signs and symptoms include the tingling and numbness of the lower eyelid, side of the nose and the upper lip, numbness in the teeth and the soft tissues, and no pain during the dental therapy. Advantages: comparatively simple and safe technique, and it uses the a small amount of the solution and with minimal amount of number of penetration. Disadvantages: psychological fear, that is administering the local anesthesia close to the close to the eye. The fear of injuring the eye is there, and anatomical difficulty in identifying the landmarks. Failure is bone contact below the infraorbital foramen or the needle deviating laterally or medially. Complications could be hematoma and positive aspiration. If at all there is a hematoma formation, immediately a digital pressure has to be applied. Followed by that, there should be an application of a cold packs, and administration of antibiotics and analgesics has to be done. Coming to the main nerve trunk block, that is the maxillary nerve block, or the second division block, can be given by two techniques, that is a greater palatine canal approach and the high tuberosity approach. The area anesthetized is the hemimaxilla, which involves all the teeth and the upper lip, cheek, and part of the nose. So where it is indicated is extensive oral surgical or the periodontal surgeries or restorative procedures requiring anesthesia of the entire maxilla on one side, entire entire maxilla, diagnostic or therapeutic procedures as in trigeminal neuralgia. Contraindications: inexperienced administrators, pediatric patient, uncooperative patients, infection and inflammation, patient with a risk of hemorrhage or bony obstruction in case of greater palatine canal. Advantages is automatic, high success rate, less number of injection, minimized number of failure. Disadvantage: risk of hematoma, no bony landmarks during the insertion, high tuberosity, pain during the greater palatine canal approach, positive aspiration is possible, and lack of hemostasis. High tuberosity approach landmarks are same as that of posterior superior alveolar nerve, that is mucobuccal fold, maxillary tuberosity, zygomatic process of the maxilla, and the target is the main nerve trunk. So here, once we are going in the same direction, once we penetrate into the mucobuccal fold opposite the second molar, and we are going in upward, inward, and upward, inward, and the medial direction, you've got to advance the needle at least up to 30 mm inside the tissue and slowly aspirate, and once it is negative, you've got to deposit the solution. Here the aspiration rate are more because we are going much closer to the pterygoid venous plexus, so the incidence of injuring the vessels or the veins is higher. Next is the greater palatine canal approach, wherein the greater palatine foramen is identified the junction of the alveolus and the palatine bone opposite the crown of the third molar, and the soft tissue is directly over the greater palatine foramen. The technique: identify the landmarks, anesthetize the area above the greater palatine foramen, locate the foramen, and advance the needle slowly into the canal to a depth of 30 mm. Once we reach that 30 mm depth, slowly aspirate, make sure you're not into the vessel, and slowly deposit the solution. So when we have inserted up to that extent, we have reached the main trunk before it gives off any branches. Failure, partial anesthesia could be there because of the underpenetration and inability to negotiate the greater palatine canal. Complication: hematoma are higher in case of high tuberosity approach. Penetration of the orbit in case of greater palatine canal approach, and penetration of nasal cavity also can happen. So being aware of the landmarks and sticking to the landmarks, we can avoid the major complications.